The following podcast is part of a certified educational activity titled Unlocking the Benefits of CAR T Therapy in Hematologic Malignancies, Latest Evidence and Practical Considerations for Delivering State-of-the-Art Care, featuring Drs. Karen Jacobson from the Dana-Farber Cancer Institute in Boston, Caitlin Costello, University of California, San Diego, Moores Cancer Center in La Jolla, Shannon Maud, the Children's Hospital of Philadelphia and the University of Pennsylvania, and Allison Siegel from the University of Pittsburgh School of Medicine, UPMC Hillman Cancer Center in Pittsburgh. Access the entire activity and complete the post-test at peerview.com/XZA860. Downloadable slides and practice aids.
I'm Karen Jacobson. I'm from the Dana-Farber Cancer Institute in Boston, and I'm really excited to be here with a panel of all women to talk about CAR T-cell therapy with you today. So this panel is Unlocking the Benefits of CAR T-cell Therapy in Hematologic Malignancies. Again, I'm Karen Jacobson. I'm here with Caitlin Costello, Shannon Maud, and Allison Siegel. So I'm just going to set the stage and just introduce CAR T-cell therapy in general, and then we'll hear from all of our panelists about their specific diseases. So just to get everyone on the same playing field, what is CAR T-cell therapy and how are they made? So a CAR is a chimeric antigen receptor. It's a chimera because the antibody molecule, because the molecule or the receptor is actually part antibody molecule, and lower left-hand picture that the blue portion of the molecule is the extracellular portion. That's the antibody portion of the molecule that has tumor specificity. And the intracellular portions, which are shown in green and red, are the T-cell activating molecules. And the CARs we're going to talk about today fall into the second generation CAR category, which have a CD3 zeta domain as a T-cell activating molecule, as well as a co-stimulatory domain. And for the CARs we're going to talk about today, it will either be CD28 or 4-1BB. And then in terms of how CAR T cells are actually made, most of the CARs we're going to talk about today come from the patient themselves. So the patient undergoes leukapheresis to collect their T cells. These T cells are then sent to a laboratory where they are activated and then transfected so that the gene that encodes the chimeric antigen receptor is integrated into the nucleus and then expressed on the surface of the cell. These cells are then expanded and then sent back to the treating center where the patient receives the CAR T cells after a brief course of lymphodepleting chemotherapy. Again, that chemotherapy is not meant to treat the underlying cancer, but is meant to make the patient a better host for T-cell expansion and activation upon reinfusion. And then, of course, we'll go through how we monitor patients for response and toxicity. There are a number of FDA-approved CAR T-cell therapies that are available that we'll talk about today. There are 3 that are approved for patients with relapsed and refractory large B-cell lymphoma in the 3rd line and beyond. That's Axi-cel, Brexu-cel, and Liso-cel. Axi-cel, Liso-cel, and Tisa-cel. Axi-cel is also FDA approved for follicular lymphoma in the 3rd line and beyond, and Tisa-cel is also FDA approved for patients with pediatric and young adult B-ALL. We have a 4th CD19-directed CAR that's approved for B-cell malignancies, Brexu-cel. It's approved for patients with relapsed refractory mantle cell lymphoma, as well as adults with B-ALL. And then finally, we have a BCMA-targeted CAR for multiple myeloma. That's ide-cel, and that's for patients with relapsed and refractory multiple myeloma after 4 or more prior lines of therapy. And with that introduction, I'm going to turn it over to Dr. Maud, who's going to talk about CAR T-cell therapy for ALL.
Thank you so much, Karen. I'm Shannon Maud from the Children's Hospital of Philadelphia and University of Pennsylvania. So I'm going to start off by talking about CAR T-cell therapy for ALL. And we'll start off the focus in pediatric ALL, and I think it's fitting that we start with this because the first CAR T-cell approval was actually in pediatric ALL, which was something that was very exciting for us as pediatricians, as it's not the typical course. So we'll spend some time talking about sort of the stage that fell into, and then talk about some of the newer data for adult ALL as well. So pediatric ALL has been really a success story for combination chemotherapy over the years, with patients with newly diagnosed ALL in recent years achieving a very high chance of long-term remission, approaching 90% in some patients. But unfortunately, for patients who relapse, and particularly for patients that relapse more than once, this curve is almost the inverse, where survival is very poor. And over the years, really, the improvements have come in reducing the risk of initial relapse, and there haven't been many advances in outcomes for patients who had relapsed, especially more than once. And so this was an area that was in urgent need of new therapies, and that's where CAR T-cell therapy came into that picture. So I'll start off with a case that really has been a typical story for patients that have been treated with CAR T-cell therapy. So this was a young man, 21 at the time of referral, but initially diagnosed with B-ALL at 8 years of age and had what we would call standard risk ALL, that in this day and age we'd expect a 90 plus chance of long-term survival without relapse. So he received standard therapy and then had a late isolated testicular relapse 4 years from diagnosis and off of therapy for about 10 months. This is typically considered a low-risk relapse, and he was treated with testicular irradiation and chemotherapy alone. We wouldn't usually use bone marrow transplant in this setting because it's low risk. He achieved a second remission, but then unfortunately had a second relapse, which was an isolated bone marrow relapse 4 years off therapy. And now this relapse was incredibly refractory. He received standard cytotoxic reinduction chemotherapy with refractory disease, and then received blinatumomab, which was investigational at the time, received the CD22 antibody moxetumomab, which was investigational at the time and was refractory to both of those agents, and then came to our center for CD19-directed CAR T-cell therapy. So what is the landscape of CAR T-cell therapy now in this day and age? So as Dr. Jacobson mentioned, Tisacel was approved in pediatric and young adult ALL in August of 2017. And so for the past number of years, that really has been the only option in ALL, and unfortunately has only been an option for children and young adults. More recently, Brexucel was just approved in October of this year for relapse refractory B-ALL in adult patients. There are a number of other clinical trials that are ongoing as well. So there's a product out of the Fred Hutch, similar to Lysocell, that is undergoing phase 1 and 2 clinical trials and is in a multi-center clinical trial right now. And then there are phase 1 trials of universal CAR-19 products. But at the time that this patient was treated, there was really just clinical trials available. And he received the product that ended up being approved as Tisacel. And I'll talk a little bit about the data that went into that approval. So the Eliana trial was an international multi-center phase 2 trials of CTL-019, now known as Tisacel, in pediatric and young adult patients with relapse refractory B-ALL. So these were patients in second or greater relapse, relapse after transplant, or who had chemo refractory disease. After enrollment, they could receive bridging chemotherapy while their cells were being manufactured, and then they received lymphodepleting chemotherapy of fludarabine and cyclophosphamide, followed by a single dose of CTL-019, which was weight-based for patients under 50 kilograms, and a flat dose for those over that. The median time from enrollment to infusion was 45 days. On this trial, and what we were really looking for was the overall response rate of CR or CRI at 3 months. And so the data, the initial data reported on that trial that was evaluated for registration was that an overall response rate, and then what I'm showing here is the duration of remission and event-free and overall survival. So for the primary outcome of CR/CRi, 81% of patients achieved a CR/CRi that was maintained at 2 months after treatment. And the relapse-free survival at 12 months after this therapy was 59%, with only 8 of the 75 patients going on to a consolidative stem cell transplant. This is longer-term follow-up data from that study that was reported at an ASH a couple years ago, showing a little bit longer-term median follow-up. And what we saw in this data was that the duration of remission was really holding up, and that the majority of relapses on this trial were really within the first 12 months of treatment, and there appeared to be a plateau. We're certainly looking at longer-term data to see if that holds up. But what this suggested was that for a fraction of patients, this could potentially be a durable therapy as a single therapy, even without consolidative transplant. The overall survival was also very encouraging. We saw that patients who relapsed were able to be salvaged in many cases. And so the overall survival out to 24 months was 66% on this trial with slightly longer follow-up. So how did this hold up when this was then FDA approved and it moved into the real world? As we know, many times those patients can be much sicker than patients who are eligible for the trial. And so I think it was really important to be able to study whether these outcomes would hold up in the real world setting. So there has been an analysis done by CIBMTR, as well as there are several consortium that have looked at real world data of pediatric patients and young adults up to the age of 25 treated with Tisacel in the real world. And what was seen on this CIBMTR analysis was that the CR rate was about 86%. This is in almost 250 patients. So this really did hold up with what was seen on the trial. And in addition, the 12-month duration of remission at 61% was very similar to what was seen on the trial. There was a slightly higher proportion of patients who went on to a consolidative transplant, in remission 16% in this analysis compared to about 11% on the trial. So I wanted to call your attention to a presentation here at ASH on Sunday on updated data from the real world setting, which looked at also the breakdown in patients less than 18 years and over 18 years, showed some differences in baseline characteristics with the older patients having received more therapies. As you might expect, there are often patients who have relapsed multiple times and having a higher disease burden, but still achieving very good outcomes and similar outcomes to the younger age group. So I'd encourage you to go see that. So as I mentioned more recently, another CAR T-cell therapy has been approved for ALL, and this is in adult patients where over 25 years of age that really was lacking for a number of years. So we'll talk about the ZUMA-3 trial that led to that approval of Brexucel. So this trial in the phase 1 setting, as shown here, was done as a dose-finding study and then moved on to a phase 2 portion. Patients also received fludarabine and cyclophosphamide in a slightly different schedule than what I showed you before, and then a flat dose of modified CAR T cells, and were followed for response after that. So the initial outcomes on this trial, You can see here out of an N of 55, the overall CR or CRI rate was 71%. And the breakdown with most patients being in CR, but a fraction of patients having CR with incomplete hematologic recovery. And they also looked at patients who had an aplastic marrow, which has been seen with CAR T cells as well. So this trial led to FDA approval in October of this year for adult patients. And I wanted to show you longer-term outcomes and the duration of remission for these patients, as well as overall survival, which is broken down here by patients who had CR or CRI, with the top blue line being CR, and just under that, the combination of both of that, and then in green, those with CRI. And what's shown in this graph to the left are when patients are not censored for transplant at the time point of transplant, and in this graph, not censored for transplant. So there's a little bit of a difference with median duration of remission not being reached when patients are not censored for transplant. This is overall survival, looking at patients who achieved remission, and then those patients who did not achieve remission, as you might expect, had a much poorer overall survival. But a few patients did appear to be salvaged and were able to survive for quite some time after this therapy. So that product is being studied in a pediatric trial as well. This is the ZUMA-4 trial of KTX-19, showing the phase 1 results. It's currently being studied in a phase 2 study. And seeing similar response rates with 78% of patients achieving CR or CRI, with the majority of those, 16 out of 18, MRD negative. The majority of these patients did go on to transplant after this. What this graph is really breaking down is a couple of different doses that were studied on this trial, as well as formulations of the product. And they found that there were some differences in safety with the different formulations, so ended up taking the lower volume formulation into the phase 2 portion. That phase 2 is currently ongoing, and an NHL cohort has been added to that as well. Okay. So what we have all seen in the administration of these products is that while there are really incredible responses, different than what we have seen with standard chemotherapy, the toxicities are also very different. And we can see some significant toxicities in the first 30 days of treatment after infusion of these cells. CRS and neurotoxicity, or ICANS, are really the main toxicities that have been seen. And so we want to spend some time just sort of talking about what the approach has been to that and how it's evolved over the years with our experience with this. So in the early days of these trials, I can tell you, I remember sort of waiting to the last possible minute to try to intervene because we really wanted to preserve the function of the T cells. And so in the initial phase 1 trials, we often waited until patients had significant hypotension on more than one vasopressor or on high-dose vasopressors, significant respiratory symptoms, either intubated or leading to that, or really rapid progression and worsening of symptoms before we intervene. And as we have all discovered over the years with these trials, intervention with cytokine blockade with tocilizumab can be very effective in reversing these symptoms or mitigating the worsening. And what has been found is that it does not appear to have an impact on response or expansion of the T cells. And so we've now moved to intervening earlier to try to make these therapies more safe and less morbid for patients. But I will say that this practice is often quite different depending on the disease and also on the patient that you're treating and their comorbidities, their age. So in the pediatric setting, we often still wait longer than I would say most of my colleagues here probably do in adult patients. But in a patient who has significant comorbidities or an older patient where a persistent high fever can be significant in and of itself, many people do intervene with tocilizumab for fever alone, even without other significant symptoms. And there have been some studies looking at that in high disease burden patients as well. In pediatrics, often we're willing to tolerate a bit more, but in a very high-risk patient, may intervene for that high persistent fever. I think what has been seen is that we're all a bit quicker to intervene as the patient is worsening. So if a patient is going on oxygen or starting to escalate to needing CPAP or looking like they're going to need that, we're often intervening with tocilizumab there. Or just at the start of hypotension, even potentially before they're going on vasopressors or if they're on just a low dose of vasopressors. The practice is still to use tocilizumab first and to try to avoid too much fluid because of the capillary leak that's seen, and then to go to steroids if not improving, and additional cytokine blockade after that, and still to try to wean steroids quickly. ICANS management has evolved too, although I will say there's still a lot we need to learn about the pathophysiology of this and what agents might improve it. But in the past, we really didn't know that there were any therapies that would help, and tocilizumab was not found to help, and there was some concern that it may worsen symptoms due to an increase of IL-6 after blockade of the receptor. Now I think a lot more people are going to steroids with signs of severe neurotoxicity and sometimes even in the early stages. And this is often dependent on the product used and the toxicity profile that's seen as well. So back to our patient. So this patient was referred for CAR T-cell therapy and received what is now Tisacel on a phase 1 clinical trial. He had high disease burden, a packed bone marrow and peripheral blast going into infusion, and developed grade 4 CRS, received tocilizumab, and did improve, although did have significant CRS. Entered an MRD negative remission and remained in remission for 2.5 years, and then unfortunately suffered a CD19 negative relapse, which some studies have shown is higher risk in patients who have received prior blinatumomab, particularly if they've been refractory. He was able to re-enter remission and undergo stem cell transplant and remains in remission. So how do we monitor for the potential for relapse and decide what to do with our patients after this therapy? One way that we and in the field have been monitoring for that is to look at how long the T cells persist and to use B-cell aplasia, as normal B cells are cleared by CD19 CAR T cells as a marker of persistence. And this is very helpful in being able to predict CD19 positive relapse, as early loss of CAR T cells, particularly within the first 6 months of infusion, is much higher risk. But unfortunately, this does not predict CD19 negative relapse, and those relapses are quite common and about evenly distributed now, and we don't have a method currently to predict that. So in addressing poor persistence, I will just quickly draw your attention to a presentation that will be given at ASH by a member of our group, Regina Myers, on Sunday, looking at reinfusion of CAR T cells for poor persistence and showing some effect of that. So in the last bit of time, I just want to talk about how we approach relapse and how we think about it. It's obviously dependent on what the type of relapse is, whether it's CD19 positive or negative. As you may be able to consider other CD19 CAR T cell therapies, even reinfusion or humanized products with a CD19 positive relapse versus CD19 negative, you will be thinking about potentially other immunotherapies if the patient has not responded to chemotherapy. And I think in many cases, particularly if the patient hasn't had a transplant, we're thinking about that in the relapse setting as well. In the interest of time, I will just sort of gloss over this, but this is some data out of a humanized CAR-19 phase 1 trial we conducted at our institution in patients who were receiving in the retreatment setting and CAR-naive setting, showing high remission rates and patients being able to stay in remission after this therapy. So in summary, we're seeing high remission rates in relapse refractory B-ALL, but I think the major problem is that there are still high rates of relapse that we would, of course, like to overcome. But up to 50% of patients may have durable remission with a persistent CAR. So I think where we're going, what the critical needs are, how can we improve persistence, through various mechanisms, reduce antigen escape, and identify patients at high risk for relapse so that we could potentially prevent that.
Great. Thank you so much, Shannon. We did have a number of questions come in from the audience about CRS and ICANS and management, and I think I'm just going to table those until Allison speaks because she's going to talk about that again. But one of the questions that came up regarding your case, or a couple of questions that came up regarding your case were, could this patient have gotten Brexucell and or Tisacel, and how would you choose at this point, given that he falls in the adult and young adult category? And then what is the role for consolidative allo transplant for these patients? Now, I think Shannon can probably talk for a whole hour on those, but we'll try to keep it. Yeah.
Yeah, it's an excellent question, and I think that they're linked to each other as well. I think that decision on which product to give and whether to go to transplant are both linked questions and very challenging decisions to make. Up until very recently, there was only one therapy that was available to Tisacel. Now, at this time, this patient would have fell into the indication for both products. And so I think what would go into my decision on which to use is whether the patient will go on to an allogeneic transplant or not. The majority of the data with Brexucell in pediatric patients has seen patients go on to transplants. In the adult population, it's more variable, and there are some patients who are able to achieve long-term remission even without transplant. But in the pediatric setting, most of these patients have gone on to transplant, and those who have not have had a much higher risk of relapse. And that is likely related to how long the CAR T cells persist. So with Brexucell containing a CD28 domain, generally what's been seen is that the persistence is quite short, usually 2 months at most. With Tisacel, a large fraction of patients can potentially have long-term persistence of CAR T cells. And so most of those patients have not gone on to transplant. And so I think thinking about the comorbidities, what the patient preference is, factors into which product and also whether you're considering transplant post.
Great. Thank you so much. And then the only other question that came in about the case was whether you had to consider only pediatric options because the patient had a diagnosis of pediatric ALL initially, or do you consider the age of the patient when they're relapsing? And I think that it seems we consider the age of the patient when they're relapsing. Okay, great. All right. So So I'm going to talk now about CAR T-cell therapies in both diffuse large B-cell lymphoma as well as mantle cell lymphoma. So obviously, there are a lot of sort of practical implications about CAR T-cell therapy. You've heard today, we've already introduced sort of how complicated this therapy is, involving pheresis and shipment to a laboratory for manufacturing, and then obviously the monitoring for acute toxicities in the first weeks after CAR T-cell infusion. So these have implications in terms of figuring out who's eligible for CAR T-cell therapy. So of course, when we're talking about eligibility, we're looking at the FDA label. So for large cell lymphoma, that's patients relapsing after 2 or more lines of prior therapy. There are some obvious comorbidities that would maybe make patients sort of less fit for consideration of CAR T-cell therapy, and those will differ from CAR T-cell treatment center to treatment center. But right now, CAR T-cells are given in a specialized center that are trained and accredited to deliver these therapies. At that center, the patients would obviously undergo their leukapheresis, and then when the cells come back, they undergo lymphodepletion, as I had mentioned previously, and then we monitor those patients closely in the first couple of weeks after CAR T-cell therapy for both CRS as well as neurologic toxicity. And then the longer-term follow-up is often shared between the CAR T-cell treatment center as well as the local oncologists. In sort of the long-term follow-up, we're really monitoring for some of these prolonged cytopenias that we see in about a quarter of patients, B-cell aplasia, and then risk of infection, and of course risk of relapse, and how to manage those relapses when they occur. So I had already introduced the 3 FDA-approved products for large cell lymphoma. It's axi-cel, tis-cel, and liso-cel, based on these 3 pivotal phase 2 clinical trials, the ZUMA-1 study, the Juliet study, and the Transcend study. So these were all given to really essentially chemotherapy refractory patients with large cell lymphoma. We know these patients generally have about, response rates of about 20 to 30% with available therapies, CR rates under 10%, and the median overall survival for this patient pre-CAR T-cell therapy was about 6 months. Here you can see the patients that were treated on these studies and how highly refractory they were, and that they were all FDA approved based on these studies. We'll go through the actual data and how it compares to some of those historical controls I just mentioned in the next several slides. So first we'll look at ZUMA-1 for axi-cel, and here you can see the response rate was 83%, the CR rate was 58%, and the median duration of response was 11.1 months, with about 40% of patients maintaining their response past 6 to 12 months. Here are some of those curves now looking at progression-free survival in all patients, in patients by their response. And so you can see that patients who achieve a complete response or a partial response, which are the top 2 curves, have excellent long-term progression-free survival, and that most of the relapses are occurring, really within the first 6 months. But if you maintain your response past 6 months, it does portend for good survival as well as relapse-free survival. We've seen very long-term follow-up for this study. So last year at ASH, we saw the 4-year data. This year, we'll see the 5-year data, which continues to show that about 40% of patients are alive. This far out, now 4+ years out from their CAR T-cell infusion, and this obviously looks significantly better than the median overall survival of 6 months with available prior therapies before CAR T-cell therapy. So that we see similar results with the Juliet study. We can see that based on response, we see patients who achieve a complete response have excellent progression-free survival as well as overall survival, and that long-term follow-up has really demonstrated that patients who respond have sustained clinically meaningful improvements in their quality of life. And here we see some updated results with longer follow-up now at 24 and 36 months, where we see about 30% of patients are alive and without disease relapse at that time point. It's a significantly higher proportion of patients who are alive and without disease relapse who achieved a complete response. And again, those sort of hallmarks of being in response at 3 months and at 6 months really does predict for long-term remission. We are going to see at ASH this year some real-world data looking at Tisacel in the real world, and the responses look similar in terms of efficacy and actually more favorable in terms of some of the toxicities that were introduced by Shannon. For the Transcend NHL 001 study of Lysocell in patients with large cell lymphoma, again, shows similarly very positive results, response rates of about over 70%, CR rates over 50%, and you can see here again for all patients, the probability of continued response is quite high. For patients who achieve a complete response, it's quite good. And then when we look again at longer follow-up, we're seeing that plateau, which is very reassuring, with similar long-term remissions. Now we're seeing 2-year duration of response and PFS on this study of about 50 and 40% respectively. So one major question that's been asked is, if they work so well on the 3rd line and beyond, what about if we move these up a line of therapy? And could these actually replace auto-transplant, salvage chemotherapy and auto-transplant in primary refractory and early relapsing large cell lymphoma in the 2nd line of therapy? And there are several phase 3 trials that have tested this. These are the Belinda study for Tisacel, the Zuma-7 study for Axicell, and the Transform study for Lysocell. These are all randomized studies. These are high-risk relapsing patients with large cell lymphoma, either primary refractory to upfront chemoimmunotherapy or relapsing within the first 12 months. They're randomized in a 1-to-1 fashion to either go directly to CAR T-cell therapy versus undergo salvage chemotherapy, and if they respond favorably, having an autologous stem cell transplant. So these studies are going to be presented at this meeting. So the phase 3 Belinda study of Tisacel versus standard of care did not meet its primary endpoint of an improvement in event-free survival. It was similar in both arms, whereas the Zuma-7 study as well as the Transform study did meet their primary endpoint of a superior event-free survival in the experimental arm with CAR T-cell therapy versus autologous stem cell transplant. So you can see the 24-month event-free survival for the Axicell arm was 41%, sort of very similar to what we see on the Zuma-1 study, whereas the 24-month event-free survival for the standard of care arm was 16% on the Zuma-7 study. And then I think one other important endpoint for these studies was that they also looked at quality of life for patients enrolled in both arms. And you can see this will be presented again at ASH, at this ASH meeting, but you can see that patients who received Axicell had a significantly improved quality of life during the time of actual treatment, during that acute toxicity window, compared to patients undergoing salvage chemotherapy and an auto transplant. And then again, as I mentioned before, the Transform study for Lysocell was also positive in terms of an event-free survival benefit for Lysocell of a median 10.1 months versus 2.3 months. And again, this will be presented on Saturday at this meeting. And similarly, they looked at quality of life endpoints and were able to show that quality of life was either improved or maintained after Lysocell compared with standard of care. And one of the questions we did get was how do patients fare after CAR T-cell therapy compared to an autologous stem cell transplant? I think what you're seeing from some of these quality of life assessments is that the sort of acute period of therapy is actually more favorable for CAR T-cell therapy. It's a much shorter period, and how patients actually experience those side effects is a little bit less significant than some of the side effects we see in the first 3 to 4 weeks after autologous stem cell transplant. I think when patients have good outcomes, eventually they end up being lymphoma patients in remission, and we're seeing those quality of life scores actually start to merge. So there are a number of different ways that are ongoing to try to optimize CAR T-cell therapy for diffuse large B-cell lymphoma. So of course, as Shannon had already mentioned, we need to improve CAR T-cell persistence, deepen these response rates, and improve durability of response. And so there are a number of different ways to modify these CAR T-cells or modified lymphodepletion to try to do this, or combine CAR T-cells with other immunomodulatory drugs. There are approaches now to try to get these CAR T-cells available to patients more quickly quickly, but not only get them available to patients more quickly, but actually to infuse sort of fitter, more active T cells back to the patient, and using various changes to the manufacturing techniques. We're looking at allogeneic off-the-shelf products. We'll see some abstracts for those at this ASH meeting as well, which would be available off the shelf, and these are T cells that are derived from healthy donors. And then to sort of combat the concept of antigen escape, we're looking at dual antigen targeting CARs, targeting more than one tumor antigen to decrease the selective pressure for immune escape. So I want to just end with a case in terms of for diffuse large B-cell lymphoma. So I have a 68-year-old patient that I treated with a triple hit large cell lymphoma. He had had 3 cycles of R-EPOCH and had clinical and radiographic progression midway through. So he was primary refractory to his upfront chemoimmunotherapy. He then went on to receive 1 cycle of R-DHAP with disease progression. He was bridged to CAR T-cell therapy with polatuzumab in this setting. This is what his PET scan looked like going into CAR T-cell therapy, and then on the left, and then on the right you can see what it looked like 1 month after CAR T-cell therapy. And this is probably the largest disease burden that I have ever seen successfully be treated with CAR T-cell therapy. This was actually a partial response at 1 month, but he's followed locally, and his response actually continued to deepen over time, and he's now 12 months out from CAR T-cell therapy in an ongoing remission. And we do see that with partial responses. About 30 to 40% of partial responses to CAR T-cell therapy with large cell lymphoma will deepen over time, and I think people are now trying to understand what are the sort of qualities of those PET responses that might predict for patients whose response is bound to deepen as opposed to those who are bound to progress. So as we mentioned before, Brexucil, which is the product that Shannon talked about in adult BALL, has also been approved for relapse refractory mantle cell lymphoma. And Brexucil actually looks a lot like Axicel, except that there's an extra step in manufacturing where the T cell pheresis product is actually purged of any circulating CD19 positive cells so that you aren't including circulating lymphoma or leukemia cells in the transfection process. So again, you want to think about who's eligible for these CAR T cells for mantle cell lymphoma. And so right now it's actually very, very broad. It's any patients with relapsed refractory mantle cell lymphoma, although as we go through the clinical trial, you'll see that all these patients were required to have seen a BTK inhibitor on the pivotal clinical trials. Again, there will be specific sort of patient comorbidities that each site will consider differently in terms of whether they are contraindications for CAR T-cell therapy or not. Patients are treated exactly the same as they were for diffuse large B-cell lymphoma. Cells are collected, and then the patient comes back and receives lymphodepletion. They're watched for acute toxicities, and then they go into longer-term follow-up. So this is the ZUMA-2 clinical trial that led to the FDA approval of Brexucil in relapsed refractory mantle cell lymphoma. Patients were allowed to have 1 to 5 prior lines of therapy, but that therapy had to have included a CD20 monoclonal antibody, an alkylating agent, and a BTK inhibitor. Patients were bridged with either steroids or ibrutinib or acalabrutinib at the investigator's discretion. They then received fludarabine and cyclophosphamide at the same doses that were done for Axicel, and a weight-based CAR T-cell dose. And then their first tumor assessment was on day 28, and the primary endpoint for this study was objective response rate. And so here you can see 67% of patients achieved a complete response following a single infusion of Brexucil for these highly refractory mantle cell lymphoma patients. And at a median follow-up of about 18 months, about 50% of patients remain in ongoing response. And if a patient actually achieved a complete response, that number was actually 70%. So this is significantly improved over standard of care therapies for patients after BTK failure in mantle cell lymphoma. And here are just the duration of response, progression-free survival, and overall survival curves for this population, which show a nice plateau. I think everybody is waiting to see, in a disease that doesn't really have a curative therapy outside of allogeneic stem cell transplant, whether this is really natural history changing and transformative how long do we have to follow these patients to say that maybe there are a proportion of patients that could be cured with CAR T-cell therapy. And at this ASH meeting, we'll see some data now looking at the real-world data of Brexucell in patients with relapsed and refractory mantle cell lymphoma. We've seen a little bit of data from the Transcend NHL 001 study of Lysocell for mantle cell lymphoma. So this was the pivotal study that led to large approval of Lysocell in large B-cell lymphoma, but it also had a cohort of patients with relapsed and refractory mantle cell lymphoma who had to have seen the same prior therapies as patients did on the ZUMA-2 study. The trial design is actually quite similar to what we saw on ZUMA-2, these are some of the early responses. So similarly, we're seeing an excellent CR rate of 66% for patients treated on this study. And the follow-up on this study is shorter, and the number of patients are smaller. But we are seeing several ongoing responses now, almost approaching 2 years. So again, I will end my discussion with a case. So this was a 55-year-old man that presented with TP53 mutated blastoid mantle cell lymphoma with a Ki67 of 80%. So every high-risk feature, and this is not a made-up case, this is a real patient. So he was initially diagnosed in 2007, at the end of 2017. He had actually been treated with 3 cycles of bendamustine Rituxan and had stable disease, then had 3 cycles of Rituxan and cytarabine, again with stable disease, and then was put on acalabrutinib, and within 3 months had progressive disease. So he was actually treated on the ZUMA-2 clinical trial in November of 2018. He actually had a very uncomplicated course despite his disease, with only grade 1 CRS and no ICANS. He was not treated with either tocilizumab or dexamethasone, actually was able to go home on day 8 after the mandatory observation period. So this was his PET scan going into CAR T-cell therapy, and these are his PET scans in the subsequent years following. So he's remained in a deep CR. Someone who didn't respond to any prior therapies had a deep CR that's been ongoing for several years. So I will just go to a couple of questions that came up. And so one question that I'm going to actually just ask my colleagues. So now seeing some of the results of the randomized clinical trials in lymphoma, actually I'm going to point it to Allison, who's also a lymphoma doctor. What do you think? Do you think this is going to be practice changing in terms of what the new standard of care is for relapsing large cell lymphoma?
In first relapse.
In first relapse, yes.
I do. I think that, as we introduce that idea, we'll see perhaps a gradual shift in practice patterns, but for high risk first relapse patients, I think that the data is convincing and it will change practice.
I agree. I absolutely agree. And I think the question's going to be, once we look at the data at this meeting and it gets published in a peer-reviewed publication, is how big is the improvement, and will this actually be practice changing for all relapsing patients or just for those high-risk patients? I think that's really going to be dependent on sort of the magnitude of the benefit of CAR in this setting, which we'll have to scrutinize with a close eye. Another question was similar to one that went to Shannon, but was, do we recommend allo transplant after Brexucell for mantle cell lymphoma? And so as you can see from, our case was presented on a clinical trial, so we, consolidating with an allo transplant would have meant taking the patient off the clinical trial. But I don't know what you do, Allison, but in my practice, I don't consolidate with an allo transplant in that setting. I think right now we're seeing very stable ongoing responses in about 50% of patients, very long-term, and I think the risks of an allo transplant sort of outweigh potential benefits given those numbers. What do you think?
Yeah, I completely agree. And I think a lot of these my mantle cell patients are older with maybe multiple comorbidities, and given that impressive plateau in the curve, it feels not worth the risk.
And then finally, as Dr. Shannon mentioned, on the Ileana study, the manufacturing time was 45, or sort of the vein-to-vein time was about 45 days for Tisacel for those pediatric patients getting Tisacel on the Ileana study. And the question was, is that true on some of these other studies? And also, I think it's also a question of, is that true in the real world right now? So I didn't talk about the turnaround time for these trials in large cell lymphoma. But what I can say is the turnaround time has improved greatly now that we have these therapies available in the real world. So for axi-cell, the turnaround time is about 16 to 17 days. That was true on the clinical trials, and it's true now. It's the same turnaround time for brexu-cell. And that what we're seeing, at least in lymphoma for tisa-cell, is a turnaround time of about 22 days. And for liso-cell, which was more recently FDA approved, we're told that the turnaround time is going to be 24 days, but we're still gathering that data. Is that what you're seeing for ALL?
Yes, we are seeing that in ALL as well, that in the real world setting, the turnaround time is much shorter, and it's about 22 days.
And so these are products that we can actually get to patients in a reasonable amount of time now, which actually means that we can actually treat many more patients than we previously could. And so it really does behoove everybody to refer their patients who meet these criteria to a CAR T-cell treatment center, because we're increasingly being able to treat more and more patients without restrictions. So it's now my pleasure to turn the presentation over to Dr. Siegel, who's going to talk about CAR for follicular lymphoma as well as CLL.
Hi, I'm Allison Siegel. It's very nice to meet you. I practice in Pittsburgh at UPMC Hillman Cancer Center. And I have the pleasure to talk to you today about CAR T-cell use in indolent lymphomas with a specific focus on follicular lymphoma, for which we now have an FDA-approved CAR T-cell product, as well as some emerging data in CLL. So let's start off with a case of a woman with relapse refractory follicular lymphoma who has received, prior to CAR T-cell therapy, a remarkable amount of therapy, which I do think we see this sometimes, although this is a bit of a dramatic and true case. So this lady was diagnosed in 2011 after presenting with asymptomatic lymphadenopathy. She was, of course, followed until for 3 years without any treatment, until in 2014 she required therapy due to the development of a paraneoplastic rash. She received bendamustine rituximab for 6 cycles and achieved a complete remission that lasted for about 5 years. Then relapsed again with recurrence of that paraneoplastic rash, and she had a subsequent scan that showed some recurrent disease that was biopsy confirmed. She received rituximab, but unfortunately did not respond and actually had progressive disease. She then received obinutuzumab and CVP, but again had progressive disease. The disease was still follicular lymphoma. She was CD20 negative at this time, however. She went on a clinical trial with combination immunotherapy that unfortunately she did not respond to. She then received lenalidomide with a partial response but relatively quick progression. She was then placed on a PI3 kinase inhibitor, copanlisib, and had a mixed response but ultimately progressed, both in her marrow and with enlargement of her spleen. A bone marrow biopsy was done that was consistent with follicular lymphoma. She then received more aggressive chemotherapy with ICE combination regimen and progressed. She then received such a long case of such a refractory patient, but received more therapies, polatuzumab followed by venetoclax with some clinical response, but progression. So finally, she was treated just this April with CD19 CAR T cells. You could see her PET scan prior to therapy, and then after receiving treatment, which she tolerated relatively well. She had grade 1-2 CRS with fever and some mild transaminitis, requiring tocilizumab, but was able to be discharged home by day 10. And then you can see her follow-up scan, which shows a really nice remission after failing so many other agents. So here is the sort of line of events that we see for someone with follicular lymphoma that is eligible for CAR T-cell therapy. So we would expect to be seeing patients that have had 2 or more lines of therapy that might be eligible for CAR T-cell treatment. They should not have active infections or inflammatory disorders. And then sort of the next few steps are very similar as to what we've done in large cell lymphoma. So the ZUMA-5 data we'll focus on now. This is the trial that led to the approval of CAR T-cell therapy of axi-cel for follicular lymphoma. So this was a phase 2 study. The planned enrollment was 160 with a focus on follicular lymphoma of 125 people. The eligibility included relapsed refractory follicular lymphoma, specifically those that had 2 or more prior lines of therapy that had to include a CD20 monoclonal antibody and an alkylating agent. The conditioning regimen was that which we give in large cell lymphoma, fludarabine and cyclophosphamide, and then a weight-based axi-cel dose. The endpoint was overall response rate, but then some secondary endpoints, including toxicity, duration of response, were also studied. So here is the response slide, and I could draw your attention to the middle bar graph that focuses in on follicular lymphoma. So analysis was done when there were 84 patients, and you can see that the overall response rate was very high at 94%, and most of those patients were complete responses. The responses that were seen were largely durable, particularly those that were complete remissions. So this was presented at ASH by Karen last year, and it is going to be updated this year as well by Dr. Nilapu, if you would like to see this. But last year we saw a median follow-up of 17.5 months, and at that time the median duration of response was not reached. And 64% of the patients with follicular lymphoma had an ongoing response. You can see in these graphs here, specifically the second one, if you look at the follicular lymphoma curves, particularly this dark blue line here, those are patients with follicular lymphoma that achieved a complete remission, and those are very durable responses. Here is the second curve, are those that only achieved a partial response, and we see a notable difference visually there. So at ASH this year, again, we'll see this updated with a much longer follow-up. It now is median of about 30 months, and we see an estimated median duration of response now having been reached at 38.6 months. And as of data cutoff, the people with follicular lymphoma, 57% of those were in an ongoing response. Here is the progression-free survival and overall survival, which, again, these graphs were from Karen's presentation at ASH last year, and we see excellent progression-free survival and overall survival. These curves are separated by those with follicular lymphoma and those with mantle cell lymphoma, which had a shorter follow-up. But even for all patients, you see that the progression-free survival hadn't been met, and certainly the overall survival was not met. The median wasn't met. The 12-month progression-free survival, to give you a better understanding, was 73% for all patients. Overall survival excellent at 92%. So now again, we have this updated at ASH this year with a median follow-up of 30.9 months, and we see that the estimated progression-free survival is now met at 39.6 months. Interestingly, we do see some separation in duration of response based on one pre-specified risk group, and that's patients with follicular lymphoma who have had progression of disease after their first chemoimmunotherapy within 2 years. That's a well-established prognostic variable. And this bar graph here was from ASCO of this year. And the response rate between these two groups, the first ones being the group that did have progression of disease within 24 months of their first chemoimmunotherapy, and comparing that to patients without progression of disease within 24 months, we can see their overall response rate and CR rate were similarly excellent. And then, however, we see at ASH this year, and this was a little seen as well at ASCO last year, that the median progression-free survival has separated out a bit. And in patients with follicular lymphoma that had progression of disease within 24 months, the median progression-free survival was 39.6 months, whereas it is not reached in those without progression of disease within 24 months. Although I would say that both of these, the durability of response in both of these groups is quite good. Here is the safety data for follicular lymphoma treated with axi-cel, and I would And note that the toxicity is comparable and perhaps a little less toxic in patients with follicular lymphoma. So about 78% of patients had CRS. Mostly that was fever with some hypotension. Only 6% of people had grade 3 CRS. So that would be requiring vasopressors. And then we see 56% of people with ICANS, or any neurologic event, 56%, and then the grade 3 is 15%. Most of that is tremor or a confused state. So this is the data from the ALARA study studying Tisacel in relapsed refractory follicular lymphoma. We will see this data updated at ASH this year as well. So in this study, there was similarly high-risk relapsed refractory follicular lymphoma patients that were refractory to 2 lines of therapy or had relapsed after an auto transplant. So they were treated similarly to Axicel, collected, although their product was frozen, enrolled. They could receive bridging therapy during the Tisacel manufacturing, received restaging lymphodepletion, which similarly to other products, it's fludarabine and cyclophosphamide, or in this case, bendamustine could be given. And then the Tisacel product was infused, and they were assessed at 3 months, as well as followed for long-term safety. Their primary endpoint was CR rate. And we can see here that Tisacel is additionally highly active in follicular lymphoma. The CR rate, 66%, and an overall response rate of 86%, and the duration of response with somewhat shorter follow-up, but we're seeing excellent data with this follow-up here of the probability of a responding patient to remain in response at 6 months was 76%. And the median progression-free survival and overall survival for the whole cohort had not been met. Again, this is updated this year, now with a median follow-up of 17 months, and we see the 12-month progression-free survival is 67%. Again, some separation based on sort of the risk group of the patient. Those with progression of disease within 24 months, we're seeing some difference in progression-free survival at 12 months, as well as tumor volume. And then the safety results with Tisacel are similar to its use in large cell lymphoma. The CR rate, or the CRS rate is 48%, but no grade 3 toxicity was seen. The neurologic events were seen in 9% of people, but only 1% were grade 3 or higher. So some take-home thoughts on CAR T-cell therapy and follicular lymphoma. We are seeing that CAR T-cell therapy is highly effective for relapsed refractory follicular lymphoma patients across risk groups, with an overall response rate dependent on product of 86 to 94% and a high CR rate of 66 to 79%. We see that these responses are largely durable. With Axicel, the progression-free survival is 39.6 months and a median follow-up of 30.9 months, and this is an FDA-approved product earlier this year. Tisacel, progression-free survival has not yet been met, with some shorter follow-up, and it is under FDA priority review. We also see that the safety profile is manageable and perhaps favorable when compared with its use in large cell lymphoma. So here's a case of a CLL patient to highlight CAR T-cell use for CLL. So this is a 66-year-old man who was diagnosed in 2018 after presenting with abdominal pain, found to have bulky lymphadenopathy, cytopenias, and lymphocytosis. His flow was consistent with CLL, and he did fall into a high-risk group, IGVH unmutated with 17p deletion by FISH. He was started on ibrutinib monotherapy, but unfortunately progressed within the first few months of treatment. Venetoclax was then trialed for a few months with no improvement, only stable disease. These drugs were tried in combination, but he had no response to this therapy as well, and so he was enrolled to receive CAR T cells on a clinical trial, but then he had, as you can see on his scan here, in the axillary region, he had a lymph node that was biopsied, which somewhat surprisingly showed Richter's transformation. So he was luckily able to receive CAR T cells as a single patient compassionate use IND, and he received those in June of 2019, and his course was complicated by CRS requiring vasopressors, making him grade 3. He did not develop ICANS. He was treated with tocilizumab and dexamethasone accordingly based on his grade 3 CRS, and was able to be discharged home by day 13. On his day 30 bone marrow and his CT assessment, he had achieved a complete response in the marrow and then a PR by CT. And the definitions for CR in CLL are perhaps a little different, but the lymph nodes need to be below a certain level. And so he actually continued to have shrinkage of his lymph node, and so at 24 months, his CBC was normal, and a CT scan showed further decrease in his lymphadenopathy, which was still consistent with an ongoing PR. So the Transcend study in Transcend CLL 004 is the study we're going to discuss here, in which CAR T cell therapy was used for CLL. So the eligibility for this trial included people with relapsed refractory CLL. They had to have either failed or been ineligible for a BTK inhibitor. If a person was high risk, based largely on presence of TP53 mutation, IGVH mutation status, they had to only fail 2 prior lines of therapy, and or if you had standard risk disease and failed 3 lines of prior therapy, and ECOG performance status was 0 to 1. So during that eligibility screen, if they met eligibility, they were enrolled in leukapheresis. Bridging therapy was allowed. I would say that to address maybe this issue in CLL, manufacturing specifically was noted to be successful almost all the time, 96% of the cases. And that patients did have to have measurable disease reconfirmed prior to lymphodepletion and treatment with lyso-cel. They were treated with a similar lymphodepleting regimen as we've seen thus far. The primary objective in this phase 1 study was safety, and then to determine the recommended dose, with some exploratory outcomes of anti-tumor activity and PK profile. The two dose levels that were explored, I don't think I can go back. There were 2 dose levels that were explored. You can see here, there were 9 patients in dose level 1 and 14 in dose level 2. I just wanted to highlight the patient characteristics. You can see that most of those patients, 83%, had high-risk genetic features. Largely that was mutated TP53 with 17p deletion or a complex karyotype. Additionally, patients had a median of 4 prior lines of therapy. All had prior ibrutinib based on the eligibility, and 65% had venetoclax. And so this is the response slide. You can see that all 22 patients here in the first bar graph, the response was 82%, 45% had a CR. With no major differences between dose levels. This study also looked at undetectable MRD both in the blood and marrow, looked at that status, and the darker blue here is the total that had achieved MRD by undetectability in the blood. That was 75%, 65% in the marrow, and that's at any time point. Here is our response data. So now there's 24 months of follow-up. This graph is a little bit busy, but you can see this is all 22 patients and what their responses were over time, with the 24-month spot here being the end of the study. And so what I would say is the responses here were durable. At 12 months, 50% were in response. And only 2 of those people who were in response had subsequently progressed beyond the 12-month point. Of the 15 people who achieved that undetectable MRD in the blood, 4 of them had subsequently progressed, and 3, that was due to Richter's transformation. So they looked at the data in subgroups here. This is a group of patients that had progressed on a BTK inhibitor and then failed venetoclax for any number of reasons. And this group is also attaining some durable responses, you can see in these first 4 patients, but, and many of those responses were rapid and durable, but there were 5 Richter's transformation events, and 4 of those did happen in that subgroup. Here is the duration of response and progression-free survival slide, which is sort of a similar message here. This is the purple line is all patients, and the in which the median duration of response was not reached. In the subgroup of BTK failure and venetoclax failure, those people did meet their progression or duration of response was 17 months. So some take-home thoughts for CAR T-cell therapy in CLL. So liso-cel monotherapy has a high and durable response rate in relapsed refractory CLL. We can see the overall response rate of 82%, many of those people attaining an MRD negative endpoint. The duration of response was not reached at 24 months. The safety profile is similar to other indications with manageable toxicity, and I didn't present this here, but there was data, I believe at ASH last year, on the cohort of patients not presented that had ibrutinib with liso-cel with very promising results. So what I think we'll be finishing up here in a second, but what I wanted to briefly draw your attention to is how we can better understand those people with large cell lymphoma, mantle cell lymphoma, and indolent lymphomas. Who is going to respond? Who will have durable responses? And sort of, is there anything that we can do to choose those people, and then things to work on to enhance durability of response? And so this is an area that has a lot of activity, and this slide sort of is based on not data that's not consistent from study to study, but each of these points has been seen in either trial data or real life data. So looking at which patients are having better responses and how can we predict that? So in the patient variable, the pre-CAR T-cell variables might be patients with lower tumor burdens, lower inflammatory markers, lacking many medical comorbidities, or lacking the need for bridging therapy. So those people that didn't need bridging therapy have a better response. Looking at the T cells themselves, that we are seeing some improved responses when the T cell product has a higher proportion of CCR7 or other early memory T cells in the CAR T cell product. When the T cells double quicker or have a higher CAR T cell peak to tumor burden ratio, that is associated with a better response. And then the tumor itself, we are seeing in some sort of interesting data, perhaps out of Stanford and other places, when there is not a CD58 mutation in the tumor, that is associated with a better durable response. If there's low tumor monocyte-derived stem cells, higher tumor-infiltrating lymphocytes, and then the absence of MYC overexpression are all associated with improved responses. Toxicity, we see improved toxicity or lower toxicity, we see increased toxicity in people with a higher tumor burden, higher pretreatment inflammatory markers, higher pretreatment monocyte levels, and then we see higher toxicity in people with higher CAR T cell levels, sort of as one might expect. As well as people who have earlier cytokine release syndrome. And here's a last slide. I would draw your attention to, up in that corner, there's a practice aid with some guidelines on treatment of CRS and neurotoxicity. But just looking here at the CRS toxicities, what are we seeing? So the common toxicities, fever, hypotension, tachycardia, hypoxia, chills, those are things that we often see as manifestations of CRS. And then things that we don't see very often but can happen and are quite serious are in that next column here. We can see cardiac arrhythmias, cardiac failure, renal insufficiency, HLH is something we should pay attention to when we're seeing severe CRS. And then finally, for neurologic events, we commonly see some confusion, encephalopathy, tremor, uncommon but serious if seen, seizure, leukoencephalopathy, cerebral edema. Again, this doesn't happen often, but when it does, it needs to be treated accordingly. And finally, here's a timeline for you to look at when we see these toxicities occurring, sort of generally across the different CAR T cell products for lymphomas. So CRS often happens early, day 2, then neurologic events can happen day 5. We might see this pushed back a little bit with some of the 4-1BB products. CRS usually resolves within a few days, and neurologic events can take a little longer. And this is seen, you can see behind it is the CAR T cells in the blood, what are their proliferation rate and sort of how that corresponds with toxicity profile.
Great. Thank you so much, Allison. And so we will get to some of those questions if we have time at the end, but I do not want to rob myeloma and BCMA CARs of their time. So I'm going to switch now to Dr. Costello, who's going to take us through CAR T cell therapy for multiple myeloma.
Thank you. And thank you, everybody. I'm Caitlin Costello. I'm from the University of California, San Diego. I am delighted to be here with you to talk about what I think is, the best disease up here. But we myeloma doctors have not enjoyed the same riches that my lymphoma and leukemia colleagues have with so many CAR T products and are just trying to keep up a bit. So I hope to talk today about the one approved CAR T product that we do have for multiple myeloma, and then talk about what's coming down in the pipeline. So without any further ado, let us move forward with a case. So this is a case of a patient, Jacob, 62-year-old man with revised ISS stage 2 myeloma. He received initial induction treatment with our typical triplet of VRD, followed by an autologous stem cell transplant, and received lenalidomide maintenance, of which he achieved a complete remission for several years. After 3 years, as we see happen, he developed progressive disease and went on second-line therapy with a triplet combination of daratumumab, pomalidomide, dexamethasone, and achieved a VGPR. But as we commonly see with multiple myeloma, this recurrent relapses that happen 1 year later, oftentimes these relapses or the duration of remissions end up being sequentially shorter. Again, developed a new plasmacytoma, rising M protein, went on next line therapy with carfilzomib, cyclophosphamide, and dexamethasone. Again, short remission time. 7 months later, progressive disease, ended up with selinexor, bortezomib, and dexamethasone, originally achieving stable disease, but eventually progressed. This is a very typical course of our myeloma patients who, fortunately, now have seen much longer remission times than had previously been seen, but unfortunately, we are still not curing people. So here he is, after multiple relapses and several lines of prior therapy, fortunately still in good health, only with some mild neuropathy in his toes. And so what is our next best option for him? Well, BCMA-targeted therapy has really become a bit of the darling of targeted therapies for multiple myeloma because it's such a nice target. It really has very minimal off-target expression in a sense that it really is solely expressed in the malignant plasma cells itself. And this allows for very limited off-target toxicity. And so there's been several approaches that have been designed in order to target BCMA, whether that is with CAR Ts, as we will touch on today. However, there are several other options looking at T-cell engagers, antibody drug conjugates, one of which is already on the market and available, belantamab mafodotin, that offers a payload or a warhead that can be kind of injected into the myeloma cell after targeting BCMA. But what's important to understand, however, is that, as I've said with this case, the patient itself has very limited remission times. There's data finally that tells us that it's just as bad as we thought it is. We have so many medicines that are at our disposal now to treat these patients, but once they've made it through their main 3 classes of drugs, however, particularly the immunomodulatory agents and the proteasome inhibitors and the anti-CD38 monoclonal antibodies, the outcomes become progressively more dismal. And so when you're thinking about triple-class refractory patients, we can see that the overall survival continues to decrease. This was the Mammoth study, which was a really helpful way to understand just what those overall survival patterns are. So if you have a patient who's refractory to a CD38 monoclonal antibody, But not both the PI and the IMiDs, overall survival is still less than a year. However, with triple and quad and eventually pentarefractory, which refers to our kind of main 5 drugs that are available in the classes of CD38 monoclonal antibodies, proteasome inhibitors, and IMiDs, you unfortunately are reaching an overall survival of less than 6 months. And so looking at this patient population, this notes a significant unmet need, looking for something that is the next best thing to offer. And here it comes. Finally, in 2019, we had some initial data that started coming out on BB2121, the initial BCMA-targeted CAR T therapy. And over the last couple of years, we've seen the KARMA study, which I'll review here, kind of continue to evolve and mature. So we have some initial data that suggest just how well this could be offered to our patients. So the pivotal phase 2 KARMA study included patients with relapsed refractory multiple myeloma who had had 3 or more prior lines of therapy. These are patients that must have been exposed to prior IMiDs and proteasome inhibitors and monoclonal antibodies against CD38 and had to have been refractory to their last prior therapy. These patients underwent leukapheresis, as we've heard previously. They were allowed to get bridging chemotherapy. They received lymphodepleting chemotherapy followed by the CAR T infusion. Primary endpoints were looking at overall response rates with secondary outcomes endpoints looking at duration of response, progression-free survival, and looking at other exploratory endpoints. But as we've hoped for, this is looking to see that one-and-done treatment. How, for all these patients who've been on years and years of maintenance therapy, this has really become an attractive option to offer this one-and-done. And so with this trial, we were able to see a dose-finding trial that showed progressive cohorts that were weight-based as well of 150, 300, and 450, where we're finally able to see some median follow-up time of about a year and a half or so. And so this was the registration trial that led to the approval of the FDA-approved dose of about 300 to 450 times 10 to the 6 cells. And so looking at who these patients are, well, they're exactly the patients who needed it. These are these heavily pretreated patients, refractory their last line of therapy. Many of them had high tumor burden. Almost all of them required bridging therapy. And as you can see there, this included a very high-risk population with about a third of them having high-risk cytogenetics and another third having extramedullary disease. These are classic high-risk findings in advanced myeloma. Again, about 90% of patients required bridging therapy, showing that these are not your smoldering patients. These are patients that have disease that is kind of exploding before our eyes. And so looking at the best overall response, looking at the primary and key secondary endpoints, we were happy after having seen how dismal the overall survival is for these patients who have had pentarefractory disease. Now we're seeing overall response rates, which are about 73%. The FDA baseline for many of our standards, I should say, for many of the drugs that get approved for myeloma as single agents are somewhere along the line of about 20 to 30%. So seeing overall response rates from a product such as this at 73% is really remarkable and kind of groundbreaking for us myeloma docs. And what's nice is that you see a very rapid time to response. About a month is the median time to response before you see that patients are starting to achieve remissions. And median time to complete remission is just under 3 months. And this was data that was after a median follow-up of just over a year or so, where you can see that there is a dose-dependent response, with the overall response rates being about, as I mentioned, 73%, but with that highest dose cohort having an 81% overall response rate just the same. And so, here we are hoping for that one and done that's going to be that long-term outcome for us. We do see that there is a dose-dependent progression-free survival benefit just the same. Those patients who get the higher doses are the patients who have the best progression-free survival overall. And not surprisingly, as we've seen with our lymphoma CAR T data just the same, the patients who do well do well. I mean, we see that those patients that end up in complete remissions are the ones that have the best progression-free survival as well. So that those patients, on average, who achieve a complete remission have a PFS of about 20 months. But for those patients, unfortunately, who are not responding, you can see that they end up developing. You can see that those non-responders are progressing much more quickly. And so overall, the PFS increased by depth of response with median progression-free survival of about 20 months in those good responders. But we also have to endure these same CRS and neurotoxicity with our BCMA-targeted CAR T therapies just the same. And again, you can see that with the increasing doses of the CAR T cells, we see the same increasing likelihood of developing CRS. And so in the KARMA study specifically, you can see that those patients with the highest dose, the dose cohort, did have about 96% of patients developing CRS. Now, fortunately, much of that was limited to grade 1 or 2, where we really saw very little advanced CRS. When it happens early in this KARMA study, usually within the first day or two or so. Most of the patients, about 2/3 of them, required tocilizumab, and about 20% of them or so required corticosteroids. Neurotoxicity itself, unfortunately, is also an issue. Fortunately, we see that it's not as common across the board. Across the board, we can see that about 20% of patients in that highest dose cohort did develop some neurotoxicity, which again, onset of time is usually about somewhere around 2 days, but it can last for about 5 days post CAR T infusion. So again, expected, fortunately low grade and similar across target doses. And so there is much to come still from the KARMA study that led to this registration of ide-cel as the first BCMA-targeted CAR T cell to be available for multiple myeloma. And I direct you to several abstracts that are being presented over this weekend that are looking at different cohorts of the KARMA study, particularly looking at baseline correlates of those patients who did achieve a CR, so we can get a better understanding, like our lymphoma colleagues, about who's going to do better from the get-go. There is also some information out there looking at different retrospective analysis of eligibility criteria, and particularly we'll look at kind of a novel CAR T that's coming up on an oral presentation by Dr. Rajay that will happen on Sunday. And so let's transition now from our one and only approved BCMA-targeted CAR T cell to the kind of next newcomer that's kind of come up next. You know, the KARMA and ide-cel really kind of threw down the gauntlet a bit to say we previously had so little to offer these patients who were at their 4th relapse and beyond, and really offered overall response rates and progression-free survivals that had been unprecedented at that phase of disease. But the CARTITUDE now is kind of starting to up the ante a little bit. So let's review the cilta-cel data. So CARTITUDE-1 was an opportunity to review the original LCAR that was looked at by the Legend, which was a Chinese CAR T that was developed originally. It was presented at ASCO ASH in San Diego a couple of years ago. So this is a dual binding domain, which is something different in terms of the construct formation that we're hoping that can allow for better outcomes. So as far as the CARTITUDE data, looking at overall response rates, again, this included about 100 patients, really now seeing overall response rates of 98%. Again, unprecedented numbers that we haven't seen. And these are patients, again, we're looking for deep responses and durable responses, seeing that patients about 90+% are achieving MRD negativity at 10 to the minus 5th. And looking at these patients and looking at their overall median progression-free survival, across the board, we're seeing nearly 2 years of a PFS for all patients with an 18-month PFS rate of about 66%. So looking at the difference now in response rate for the cilta-cel product relative to the ide-cel product that is approved, the next question comes up is the toxicity any different? And so looking at the cilta-cel data, you can see that these patients also do have significant amounts of CRS on the range of about 95%. What's different, however, it seems as if the time to onset is significantly later. This has pretty great implications for logistics, preparation, and potential outpatient implications for administration. But the duration of time overall, if it were to occur on as a median date of about 7 days post-CAR T, the median duration was approximately 4 days. The same interventions can occur with tocilizumab and corticosteroids, where the great majority of patients did receive something. And if you look at the comparison between cilta-cel and ide-cel, what you can see there's nearly equivalent CRS rates, nearly equivalent tocilizumab rates across the board. We will get to the neurotoxicity in just a moment, but you can see that the maximum CRS grade across usually was just on the range of about grade 1 and grade 2, so no significant CRS activity there. That's different. The neurotoxicity, however, may be a slightly different story, and it remains to be seen how this is going to play out. So in terms of neurotoxicity for cilta-cel, there was increased neurotoxicity with slightly greater, higher grades of neurotoxicity with the cilta-cel product relative to the ide-cel product. However, what was different is that we could see that the patients, once they had the development and subsequent, improvement of their neurotoxicity associated with the product, however, did start to develop some late neurologic toxicity. There were some patients who had their ICANS entirely resolve. However, there were patients who developed other neurotoxicities later. There was one, for example, that developed CNS cranial nerve palsies. And there are some patients that did end up having later term neurotoxicity, upwards of a month or so post-CAR T infusion. And so looking at these neurotoxicities, we need to have a little better understanding about who's going to develop them, what are these late onset neurotoxicity, and the time to recovery just the same, because some of these neurotoxicities that happened post-ICANS had a median duration or time to recovery of about 75 days post. And so there's very promising responses in terms of the cilta-cel data looking at the overall response rates and the progression-free survival. However, we really need to have a little better understanding about these late neurotoxicity events that are happening with cilta-cel. And the PDUFA date was originally set for November. This past November was pushed forward to February, so we anxiously await that update. The CARTITUDE-2 data here now is looking at a couple of different cohorts. So this is a phase 2 study looking at cilta-cel safety and efficacy. There's 2 cohorts looking at patients who are lenalidomide refractory with earlier lines of therapy, including patients here with only 1 to 3 prior lines of therapy. A separate cohort is looking at patients following early relapse after their initial therapy, so presumably those patients who have very high-risk disease after receiving initial induction therapy with a proteasome inhibitor and IMiD. These patients receive a single infusion of cilta-cel and would lead to very early and deep responses. And so again, looking at an opportunity now here at ASH, we're going to see updated analyses how these cohorts A and B are faring now in earlier lines of therapy with cilta-cel. And so I point to you for a number of abstracts here at ASH this year, looking at follow-up of cilta-cel, trying to get an understanding, as I mentioned, about adjusted outcomes or comparisons for various therapies and real-world settings for cilta-cel, looking at patients particularly who are getting cilta-cel earlier in their disease course than what we've previously seen the ide-cel approval for. So much to be seen here in terms of updates here and subgroup analyses at ASH 2021. And so I put this up here to say as though we have one approved BCMA-targeted CAR T-cell, one that's kind of nipping at its heels, but there's just so much more that's coming. This has really been an explosion of CAR T products, all targeting BCMA, all with slightly different constructs, different manufacturing processes, transposon-based therapies. There's a lot of excitement in terms of which is rushing the finish line that is going to finish up here late, including some allogeneic off-the-shelf BCMA-targeted therapies, which is going to be important in this patient population, which more often than not has seen corticosteroids and has been wildly, beat down by, their lymphocytes have been beat down over the years with all this treatment, where oftentimes CAR T or T-cell apheresis and production can be challenging. And so by giving healthy donor T-cells, I think this is really going to have an important role for the management of multiply relapsed and advanced refractory multiple myeloma. And so here we are targeting BCMA really has become the new standard in terms of treating patients with advanced disease. But the question that comes up next is, well, which one do I use? We have this bit of an embarrassment of riches now that we have so many options to do it. But I think there's a lot of different details we need to consider, including can any of these therapies be given in our community by our local oncologists, or do they all need to be given at academic centers? There are novel drugs, but that usually means novel toxicity just the same. The antibody drug conjugate that has been approved by the FDA, belantamab, which is that BCMA targeting antibody drug conjugate, has developed corneal toxicity, which has been a whole new ballgame for many of us, oncologists who are very comfortable with hematologic toxicity and CRS and neurotoxicity. Suddenly these patients have to see their ophthalmologist before every single dose. And so while this may offer a nice outpatient option, it does develop some complexity to treatment. But the T-cell engagers itself, again, is another new thing that's coming. While we don't have one approved quite yet, there are many that are in development that they can be given both as subcutaneous and intravenous, and just trying to keep up with our CD19 T-cell engagers just the same. We see the same CRS and neurotoxicity, but oftentimes it's limited, just like with blinatumomab, to the first dose, where maybe this is an opportunity for patients to receive their initial doses at the academic centers and then can transition for the subsequent therapy to home to their local oncologists. And then CAR T cell, as I mentioned, one and done. Maybe this is an opportunity to give us prolonged therapy or one therapy with prolonged remissions if we're giving it probably, at the right time in the disease course where it's going to have the most maximal impact. The problem we have right now is a little supply and demand problem. One CAR T with a whole lot of myeloma patients that's out there means long wait lists. And so we are all kind of anxiously awaiting more supplies so we can meet the demand that our patients really need this. And so to revisit Jacob, our patient, remember this is a patient with multiple relapses, now asking the question, is he a clear candidate for BCMA targeted CAR T cell? And here he is. He's had his 4 lines of therapy. He's in excellent health. He has a good performance status with minimal toxicity. This is exactly the person we want to see at the academic center so that we can proceed with CAR T. Please send these patients early. These are the patients that if it's going to have some wait lists, unfortunately, or it's going to take some manufacturing time to do this, we want to get those patients in, authorized, worked up, confirm eligibility so that we can move towards CAR T when their kind of lottery ticket, it feels, is drawn.
Thank you so much, Caitlin, and thank you all for sending excellent questions.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/XZA860. This activity is supported by independent educational grants from Kite, a Gilead company, Legend Biotech, and Novartis Pharmaceuticals Corporation.